health equity approach looks like. How does it work? What does it look like? And how can we apply it to our maternal infant health programs? So we have a few discussions, but if you do have a pertinent question, feel free to send it in the group chat. Otherwise, we're going to have a lot of discussion time at the end. So, okay, so healthy people objectives were established by the CDC, and they really reflect the priorities of the country. And what's interesting is that the priorities have actually changed. Someone forgot to mute themselves. Okay, Raquel will take care of it. Okay, I guess I got muted too. So in 2000, the objective was to reduce health disparity among Americans. And then in 2010, it was to eliminate, not just reduce the disparities. And now we're under Healthy People 2020, and we want to achieve health equity. And you can't do that without eliminating disparities and improving the health of all. So we're going to focus on that. I just wanted to show you that it is a national effort. And it's also an effort, a work that is very central to the New York State Title V MCH service block grant. It's in their 5-year action plan, I believe.
Everybody hear this? Because I'm afraid to move it.
Okay, everybody settled? So community listening forums are going to be used to develop the new DFH procurements. And if you remember, there were pilot listening forums that were conducted in Queens, Binghamton, and Rochester. So that information is being analyzed, and the tools and resources developed are available to all the MIDGE programs. And the information can be used to inform the upcoming procurement, as well as actually in all the upcoming DFH procurement. So again, it's not just national effort, but it's also very important to us in New York State. So let's start by defining the concepts. We're going to focus on health disparities, social determinants of health, and then more deeply look into health equity. So I know you know health disparities. I'm just quickly going through the definition. So it is the difference in the incidence, which means the number of new cases of whatever health problem, and how prevalent that issue is. So all of the current cases for whatever health condition or health status between groups. So the difference in health outcomes between groups based on whether it's race, ethnicity, socioeconomic status, sexual orientation, gender, etc. So any difference in health outcomes between groups based on social issues or economic. So how do these disparities arise? So I'm going to use Camara Jones' cliff metaphor, which obviously I've adapted, doesn't look like hers, but the idea is the same. So I'm sure many of you have seen it, but just in case, we'll do a refresher. So we have a cliff that we're all headed towards death eventually, but we want to arrive there when we're old and have lived a full, healthy life. So some of us are getting closer to that cliff because of our habits, because of social issues, many different reasons. So in order to warn people, we have a lot of general campaigns, especially since we're talking about maternal and child health. We want to make sure they know about the services around them. we want to conduct outreach in the community to talk about issues such as breastfeeding, for example. I remember in Rochester, we had a big campaign and had posters about breastfeedings all over the city and the bus stops, etc. So those types of issues, basically warning people, informing people about some of the issues. But of course, some of us, we know what to do, we know what's good for us, but we still carry on. In that case, we want to build a fence that will protect people from falling off the cliff. And that fence could be programs such as preventing any pregnancy-related issues. So we're talking about helping women change their behaviors, such as not smoking during pregnancy, or other behaviors such as healthy eating, using prenatal care early. So all of these issues, we tend to deal with the specific services, preventive services for women, focus on their behaviors primarily. So you know how behavior is. We may know about it. We may be helped on how to do it properly and given the opportunities, but some of us still manage to fall off the cliff for whatever reason, and we'll talk about some of those reasons. So we want to build a net, or preferably a trampoline, so that when people fall, we can catch them before it gets really bad. So those are, we're talking about screening, and detecting any pregnancy-related problems before it gets bad. So it could be monitoring diabetes and treating it during pregnancy, or it could be any other issues, preeclampsia, for example. So if we can treat them, catch them and treat them, then that works. So they don't fall through the cracks and have really bad outcomes. But again, some of us still, we miss certain people in our services, or for whatever reason, they develop really, really bad conditions. So here, we want to make sure that, for example, if a woman has preeclampsia, and it turns into eclampsia, we want to make sure that the baby who's born preterm will have the care necessary to do well, to survive. And perhaps we want to follow up with the mom to make sure that she doesn't develop blood pressure after delivery, or other examples like that. So that's tertiary prevention. So we want to make sure there's a care available. So if you fall off, you want the ambulance to be there very quickly and to take you to a healthcare service where you can get what you need, and well, they'll take care of you. So this is the ideal world, but we know that if the blue people have it a certain way, there might be green people that are actually a lot closer to the cliff for determinants of health that we'll discuss later. So for those, perhaps the speed bump, if you want to call it, the big campaigns or the information available in the community, maybe it's not culturally relevant. So some of them understand it, some of them don't, because they either speak Spanish or they have a low level of education. For whatever reason, that speed bump is not solid because of the information shared. So a lot of them fall through the cracks and heading to the cliff. And this is basically the differences in exposure, the environment, and the different opportunities that they have or don't have. So we build a fence, or maybe their fence was built a long time ago, it hasn't been updated, it's kind of broken down, and not enough services, not adequate services, or maybe they don't know about the services. For whatever reason, they also, while the blue people might be caught in the net, they fall right through and have some serious problems during pregnancy. So differences in access to care needed makes a big difference. Some have better access than others. So if you're the green person, let's say you're in a rural area, you're a woman, you have a complication with your pregnancy, you need to get to the hospital for a C-section. and you're waiting and the ambulance is coming slowly. It's really far. It's coming slowly. So by the time it gets to the woman, there might be a lot more complications, and compared to the blue person, where the ambulance was nearby, the hospital was nearby, and everything was very available. So for whatever reason, there are differences in access to care. There are insurance differences, there are geographic differences, racial differences, etc. And then there are differences in the quality of care. So how quickly does the ambulance get there? How quickly do you have access to those services? And how great are those services for the population that needs it? So, so when we talk about maternal and child health services, we're talking about prevention at very different level. So the general outreach in the community, the specific behavior modification and other services that many of the CHWs provide, and more secondary services, which are screening and detecting problems and addressing them early, addressing them as soon as we find out.
Okay, so this
And
I
then,
know. I've never had this before.
am I unmuted or muted? Okay, and then the healthcare services for maternal and child health that make sure that they're available and that they're appropriate for everyone. So, so when we're talking about the determinants of health, a lot of what we do in maternal and child health is really focused on that primary prevention, which is focusing on the individual, secondary prevention, and tertiary. We focus on the individual determinants of health. So what does that entail? That's we're talking about behaviors, we're talking about individual screenings, individual education, etc. Individual insurance for the mom and of course the child, the infant. So we do a lot at the individual level in our programs. We may do some in the social determinants of health, which we'll come back to later. We're going to focus on that. But I wanted to mention that when we talk about social determinants of health, which I'm sure all of us have heard so many times, we need to remember that it's part of an entire set of determinants of health. So there are individual choices that we make that impact our health, that determine how healthy we are. There are social factors that impact how healthy we are. And then there are more societal, broader issues. So for individual, it can be genetic or behavior. But for societal, we're talking about policies, we're talking about larger systems of power that provide the context for many of the social issues and the inequalities that we have today. So just remember, determinants of health are very broad, and social determinants are just looking beyond the individual and to its community and its where it's living. And then all of the policies from the societal level does impact the environment as well as the individual. So I just wanted to get the broad view before we focus on social determinants of health. Can you name some of the social determinants of health? Can we have like 4 social determinants of health? Anybody want to type it in? 3 or 4 social determinants of health that you've heard. Make sure to reply to everyone so I can see it. Nothing? Okay. Housing conditions, absolutely. Living conditions, poverty, income, etc. Right? Definitely. There are many others. Access to education, the quality of education, absolutely. So you're naming them, definitely. Lack of insurance, healthy food, etc. So basically, social determinants of health are those resources that we need to enhance our lives, to make sure that we have a good quality of life, and that we have a long life, rather than, so we're not falling off the cliff too early, but live long. So you mentioned, I guess, all of these, I think, and more, but it's basically the life resources that we need. We all need a good food supply, we all need housing, we all need good relationships that are social as well as economic, transportation, good education, good healthcare. So I think that summarizes just about everything that you mentioned, but there might be others. So all of these are the factors that impact where we're born, where we live, where we play, where we work, grow old, etc. So this is the general ideal, but what's the reality? So some of you provided, talked about no insurance, pollution, etc. So in reality, we don't have equal distribution of these resources. There are a lot of inequities in the way the resources are distributed. So, I mean, you have, I listed a few in case we didn't get to all of them, but there are many others. I see one, so income, education, discrimination, the built environment, the neighborhood and the way, what it looks like and what's available, stress, unemployment or the type of employment that's available, housing, etc. And the fact that a lot of the communities that are not as affluent have so many fast food restaurants, a lot of corner stores, a lot of liquor stores. So the food environment is not ideal, and there's not always access to good food. Others, I mean, there's violence in the community, right? Which would be part of the built environment. So the reality is many communities, especially the ones that we work with, have these are their social determinants of health, which means their health outcomes are not ideal because of these issues. If you also notice, only a few are actually directly health related. But you can see how all of this actually does impact the health of the women that we serve. So what about the social determinants within the neighborhood? If we just pick the built environment or the neighborhood or community, what are some of the factors that are very specific to a neighborhood that might be a social determinant of the health of the people who live there? Can we get 3 or 4? Okay, violence, drug use, absolutely. It impacts a lot of things. If there's violence and a lot of drugs and gangs, then you don't feel safe. There's stress. The housing may not be affordable. And sometimes when it is affordable, it's not quality. It has perhaps lead, etc. The quality of school within that community would be an issue. And we know that poor education leads to many, it really impacts the future of that woman and the child. Lack of banking institutions, a lot of cashing places, which they can charge whatever they want, and lack of transportation, etc. So there are many of these. So I'm just going to put safe places to exercise. Again, most of these you've mentioned. Pollution, air quality, water quality, fear, stress, anxiety for whatever reasons. And there are also the norms, the role models that people have and the peer pressure for getting pregnant or not. I know that in some communities, the young men used to talk about how proud they are that they have 3 babies from 3 different young women. And that's not the norm that we want in our communities. Having a baby is not a competition. So anyway, a lot of cultural and norm issues as well that we can't forget to address. So health equity. So far, I think all of this was a review. But health equity is defined by Healthy People 2020 as the attainment of the highest level of health for all people. So the only way to achieve health equity is to make sure that you value everyone equally, and that we focus on addressing some of those inequalities in resources and inequalities that are due to historical injustices. And also we need to really address disparities between populations. So bottom line, we want everyone to have the opportunity to attain their full health potential. No one should be disadvantaged from achieving this potential just because they're from a certain class or make a certain income or look a certain way or come from a certain country. So everyone should be able to attain their full health potential. So that's a very idealistic goal, but that should be what we strive to achieve. So before we go more deeply into health equity, if we compare, just to review the three concepts that we defined today. So health disparities are the differences in health outcomes between groups based on socioeconomic status, gender, race, etc. The social determinants of health are those resources that we need to have a full quality of life and a long life as well. Health equity, on the other hand, is the opportunity for everyone to attain their full health potential. That means equal access to all of these resources that we named in the social determinants of health. So basically, if you don't mind me using this graphic, again, I am using someone's graphic and I kind of tweak it to make it my own, and I'm trying to find my mouse. This doesn't work. Oh, there we go. Okay, so this is three groups of people. They're all striving for the apples, which will pretend it's like the full potential of health. Some are closer, others are not so close. So that's what we call disparities, is the difference between these groups. Some doing better than others. So again, people who have experienced the health disparities have much further to go to attain their full health potential. So if we were to have an intervention that is the same for every group, well, we've helped everyone, right? But it looks like the ones that were closer over here have actually attained their full potential. They're doing much better. Whereas the others, they are closer, however, they have not reached their full potential. So there's still disparities. So we have not eliminated disparities. We may have reduced them, but we have not eliminated. There's still differences between populations. So if you have equal implementation, you may have improved health in general, but if you look at different groups, you'll see there's a big difference. And my favorite example is when you look at infant mortality, the past 100 years, how much we've really reduced infant mortality in the United States because of all the scientific discoveries and the health system improvement. So if you look at our country, we've had tremendous improvement in infant mortality. However, if you look at African Americans, you'll see that even though we improved in our health outcomes, our infant mortality, there's still a huge gap between white outcomes and Black infants' outcomes. So we need to address the disparities in infant mortality by race. So just an example. So on the left here, you have equality, meaning everybody gets the same interventions, the same assistance. And on the right, you have health equity. That means you give the people with the most needs, you give them the most help, the most services, different types of interventions to meet more of their needs. So the interventions themselves cannot be equal if we want to reach health equity. Some people had more advantages than others. Some people were born into families that were more advantageous than others. So we have to see where people are and identify their needs and meet those needs based on where they are in life. So that's what we call equity. So if we're trying to, so I just want to go through the principles and approaches quickly. The main approach is that you have to focus on the most disadvantaged groups, so that they can have the opportunity to reach the objective. We need to reduce health disparities and try to improve the health of those who are the most disadvantaged. And we have to address socioeconomic differences in addition to everything else. So you can't, all these really should be done at the same time if we want to start thinking about health equity. So Whitehead and Dahlgren, they identified 10 guiding principles that I thought were, you know, pretty good, pretty general. That the policies that want to support health equity really should be bottom up or level up, not level down, if we want to understand what's going on in the community and really meet their needs. The approaches that we just mentioned, focusing on the disadvantage, reducing health disparities, and the differences by socioeconomic status, those three are interdependent and should build on one another. Population health policies should promote health gain as well as reduce health disparities. We should be concerned about tackling the social determinants of health inequalities, not just what we consider to be the direct health services, but also some of the social issues that our women face. Some policies, the intention may be great, but it's not enough. So we need to be sure that whatever policy we implement is not doing harm. And in order to do that, we have to monitor and assess the impact it's having on various populations. So it may be great for one population, but not for the other, for whatever reason. So we need to monitor and make sure that everyone is gaining, especially those who need it the most. So here an example is in Hillsborough County, Florida. We focus so much on teen pregnancies among Black girls, or young women, that we actually reverse the disparities. So the white young women, white teenagers, actually ended up having more teen pregnancies than the Black. So although I'm glad that we don't have disparities, we don't mean to create a reverse disparity as well. So the idea would be for everyone to improve and reach the goal. So we also need to have the tools to measure the extent of our progress towards health equity. It is, like I said, it's an ideal goal, but we are progressing towards it. And it's important for us to measure how well we're doing and how much efforts we need to put in. And also, are we really reaching the people that we need to reach? Seventh principle, they talk about giving a voice to the voiceless, and analyze social inequities by men and women, because there are different inequities for men and women, especially when we talk about reproductive health. Also look at differences by socioeconomic position, or ethnicity, or where people live geographically. So the bottom line is the health systems really need to be built on equity principles. And this means providing according to what people need, not whether they're able to pay or not. So this is a bit difficult because the healthcare system is very much driven by profit, and it makes we need to make sure that we're helping those who can't pay obtain quality care just like everyone else, and the highest standards of care for everyone. So these are 10 guiding principles. I know I went through it a bit quickly, but I believe you have the slides. So you can review again, or we can talk about some of them if you have questions at the end. So health equity and maternal infant health. Let's specifically look at maternal infant health. So we have a lot of disparities. We talked about Black-white disparities and infant mortality. There are many other disparities by income and by race and by immigrant versus non-immigrant status, etc. But those disparities really affect children and mothers the most. So if we wanted to use a health equity approach and reduce health disparities to improve the health of all mothers and infants, we really have to address the underlying factors, or what we're calling social determinants of health. And we also have to use a life course approach to address the social determinants of health, meaning we want to help women and young girls before they get pregnant, not just wait until they get pregnant. So, and I know what we talked about the life course quite a bit in the past. So if we address the social determinants of health, we want to help women make healthy choices, and we want them to do the right thing. We want them to exercise, to eat right, etc. However, we know that they can't do that if the environment is not conducive to that. So we have to also make environmental improvements to make sure that the women we serve also have sidewalks, have opportunities to exercise, that there's less violence and gang activity in their neighborhoods so that they can safely walk without worrying. And we also know that a lot of the environment is based on policy, so we need to look at our policies and start looking at which ones need to be improved, which ones need to be instituted, etc. And bottom line is we need a systems improvement in the entire the entire community, and of course, here's my graphics again. We can't do this alone. So health equity would look like this. All people, no matter who they are, no matter what they look like, the blue people, the brown people, is that brown or red? They all have equal services. They all have access to equal interventions, no matter what their background is. So that would be equity. So if we're looking at individual, we can't lift the burden of health by ourselves, is what I'm trying to say. So the health burden is huge. So if we try to do it individually, either as an agency or in an individual program, it's a lot of work. It's like pushing a huge burden up a hill. So if we work together with other institutions, we can actually make that hill a little bit easier, and we can reduce the health burdens and arrive to the top, or whatever we need to be. So it makes the gap much less if there's a systems approach or everybody working together. So I want to touch a little bit about the societal determinants of health. I think we're pretty comfortable with social determinants of health, and if you have questions, we can definitely discuss them later. But when we talk about societal determinants of health, can you think of any specific ones? Any specific policy that you think might impact maternal infant health? Universal health care, yes, definitely. And actually, these days I'm getting a little concerned about healthcare policies in general. Anything else? Paid family leave, definitely. So any policies that dictate access to care, banking, zoning, absolutely. So these policies can be institutional or governmental, of course. Inadequate benefit levels in the SNAP program, transportation routes determined by usually the mayor's office, and public assistance policies, affordable housing policies, etc. Yeah, absolutely. So not providing interpretation service, absolutely, whether it's for the deaf population or for speakers of other languages. Absolutely. So I want to talk, I'm glad somebody brought up paid leave, because I want to use a couple of examples to show you the impact of societal issues. So if we look at parental and sick leave policies and its impact on maternal infant health, the literature tells us that if we had parental and sick leave, it would improve, it's been linked to improvements in infant mortality, the health of infants of mothers, has an impact on breastfeeding, on immunization, well child checkups, maternal depression, occupational injuries, routine cancer screening, emergency room usage, and days lost due to illness. So, I mean, if we think about it, even without seeing the numbers, that makes sense. For someone who's a wage earner or hourly, paid hourly, taking 2-3 hours to go to the doctor, to take your child to the doctor, or to go to your prenatal checkup might be a question of, do I want to give up, can I give up that money or that income or not? So we're forcing people to choose between the well-being of their children, for example, and their getting the income to feed their children and house their children. So definitely, and that could be the same for all of those. Infant mortality, that would be an indirect link, because if it impacts prenatal care or maternal depression or lack of screening, a lot of these can lead to infant mortality, poor birth outcomes. So if we were to have an equity approach to this, what would we want to do? Do we just force all the institution? Do we just change the policy and have paid parental and sick leave for everyone? Okay, nobody's typing in yes. So yes, of course, that's one way, but is that the only thing we can do? Some of you are actually helping with this by offering after-hours care, so that the mother does not have to worry about taking off of work, but she can go after work or during the weekend. So yes, and maybe we can have services. Someone's suggesting having services closer to where the women are. That would help with the time issue, definitely. Offering services at hours outside of work is also another way to do this while we're waiting for policies to change, because we know how long that can take. So there are things we can do, reaching out to employers, have service at a time for people that work. Oh, okay. Advocate for breastfeeding at work, for example, having a space for women to breastfeed. So a lot of these, some of these are institutional policies, and others are much broader than that. So again, we don't want to wait until the policies change, but we want to try to see what we can do in the meantime. So thanks for your contributions. So I wanted to show you some of the numbers. I couldn't find very recent ones. I'm sure they're out there, more recent ones, I mean. But here's an example from 2014. This is access to paid leave by income for everyone, for all the civilian employees. So you can see that if you are, my mouse doesn't want to, okay, I'll just use, it's there? It's, there it is. So if we see, this is by income percentile. So obviously the lower income, the less paid leave you have. And most of these are hourly wage earners versus those in a higher income are the ones that do have paid sick leave. So there's an inequity here that we would need to address. And some of the ways to do that is what you mentioned, what we just talked about. So this one is specifically mothers' access to paid leave by education. So if you just focus on the blue columns here, again, it's similar to income. The more education you have, the more paid leave you have. And the less, of course, you have less. So again, this is by education for women, and this one is by income. So there's definitely a correlation between lower income, lower education, and lack of paid leave. So there's got to be something that we can do, some policies that we can come up with to address this long term while we try to work with women and work around their employment issues here. Okay, so this is another example from California about some of the strategies that they came up with to move towards health equity. So it's not necessarily maternal and child health, but it's public health and it's very broad. But if you look at some of the items, it really, it's a framework that this community has developed to show the different factors from all different areas. And they use the upstream, downstream approach. So the work that's at the individual level here is considered downstream, and then the more broader policies are considered upstream. The current approach, and I think we can see a lot of our services here also, are very much focused on the individual. So if you think about the little cliff and the different, the speed bump, the net, the fence, that's what we do. We address behaviors, risk behaviors at the individual level, smoking during pregnancy, nutrition, physical activity during pregnancy, or preconception or post. And then we try to detect diseases and problems with women of reproductive age, whatever it might be, diabetes, high blood pressure, HIV, and we want to impact the outcomes of the infants and the mothers. So we do a lot at the individual level, and we also work a lot with other healthcare agencies for various health services, for health education, and they call it case management. So for case management of the people they serve. Again, this is very much what we do, working with women and families, providing health information, making sure that women have health insurance, et cetera, and referrals to other services. So that's at the individual level. So, but the new approaches, especially towards equity, is we have to look at more broader issues. We have to look at the social and the societal determinants of health as well. So we need to look at social inequities by different social statuses, whether it's income, race, ethnicity, immigration status, gender. We have to look at institutional powers. So we talked about the banks earlier. We mentioned schools, a lot of the laws and regulations that impact businesses. We also want to address the physical environment, the social environment, and the economic environment where the women we serve are. So we talked about housing, transportation, under physical environment, and many others. Social environment, we talked about cultural norms, we talked about race, etc. For economic and work environment, of course, there are unemployment issues, the type of employment that leads to, that has policies that are not conducive to reproductive health, such as paid leave. And what else? Occupational hazards, of course, and then also the service environment, healthcare, educational services, social services. Make sure they're available and that they're appropriate. So this is going a little broader, and of course, we should be doing a lot of community capacity building, community organizing around various policies, various issues happening in the neighborhood, and working together towards that. So all of this, training, collaboration, awareness raising of different issues, all of these we cannot do alone in maternal infant health. Again, we keep coming back to this systems approach that we've been speaking about a lot since the conference last May. So we cannot address the policies, the social inequities, the living conditions without working with agencies and nonprofits and various organizations that offer these services and are specialists in this work. So we have to have strategic partnerships. So if you think about the different sectors that you filled out for the partner survey that we did, do we have the right partnerships to fill the gaps that we cannot in our current partnerships? So bottom line is we have to have a systems approach, and we have to think more upstream rather than downstream when we are trying to reach for health equity for all our women and infants. So I hope that was helpful. Any questions about this? Okay, we can discuss it at the end when we have questions and answers. So achieving health equity, we have to have a holistic approach, and we have to involve many, many different sectors in order to improve the lives of women and infants and their families, their communities as well. We have to work with other folks, other agencies, and organizations. And we have to support policies that create health promoting communities and bring evidence to those who have the power to change policy. So I'm going to give some examples for each. So if we want to improve the living conditions, we have to work with housing. We have to think about working, I don't know, with the police force or the justice system or the mayor to address violence in communities, and also pollution, for example. For protecting populations against disease promoting forces. So we're talking about, an example is the presence of fast food and corner stores in many of these communities, the concentration of them in the communities. The targeted advertisement of food that's not really good for you. This is especially for children, the impact it has on children wanting to eat something just because Dora's on it or something. So there's a lot of targeted advertisement for cigarettes, for many food items. And I apologize for those who are cat people. Also, physical exercise, which is very much tied to some of the conditions in the neighborhood. So for supporting strategies that create healthy communities, we want to make sure that there are safe places for physical activity, so we don't look like that cat. We need to increase access to healthy food, and like I've mentioned before, in Rochester, we have a lot of farmers market that we try to, Food Link especially tries to provide to low-income communities. Also using public space to promote democratic participation. It's these days, especially the next 4 years, I think we may have to really combine our efforts to make sure reproductive health funding remains, and that we promote the needs of the women that we serve, to make sure that, I'm trying to be politically correct, but we may want to join forces to with the communities to address some of these issues. Bringing evidence to those who have power to change policy. So there are a few things that can change policy, is really making the powers that be aware of the problems that we face. The number, what are the statistics? What are the outcomes in maternal and infant health care? What are the issues that we need addressed? What are the policies that we need addressed? So we can spread information, disseminate information. We can testify before Congress. We can have community peaceful protests. We can have community engaging, organizing themselves to address a particular issue, like this one here. So there are ways to do it. Of course, to do that, we have to have scientific evidence, statistics, and we have to be able to tell everyone that how successful we've been, so that we can continue to be funded, or we can impact policy. Of course, social movements and community organizations are always important for impacting policy as well. So basically, if we want to reach equity in maternal and infant health, we have to address social and societal determinants of health. I keep repeating it, but this is really what it's about. We need to address the needs of women before they get pregnant, during pregnancy, and after delivery. So really look at the entire life course. Collaboration and partnership, a systems approach, absolutely crucial for achieving health equity for women and infants and their communities. These are men, but pretend they're women. So if we want to reach for health equity and reduce disparities, bring us closer to reaching health equity and optimum health for all. If this were for maternal and infant health, what kind of programs do you think we could design to reduce health equity, health disparities, and then reach health equity? So this one is just general, but if we had to create a list of programs, plan a list of programs for maternal and infant health, what would they be? So we can talk about this, and I'm really at the end of the presentation, so we can talk about this and then discuss any comments that you may have and questions. So this is how, okay, have services, advocate for workplaces. Okay, that's the earlier one, sorry. This is how the New York State Department of Health designed MITCH. NESPA, we, yes, definitely. I think that is the aim, is to work together to address some of these issues. Someone's asking if there are examples of evidence-based programs specifically to improve maternal infant health. So there are many, and I know that we've worked on, so the COE, we're working on collecting some of these evidence-based based programs in different areas. There's so many, so we're grouping them by, I'm blanking out. What are some of the evidence-based reviews that we've done? So on how to conduct outreach, on LARC, healthy weight management, diabetes. There's so many out there. So yeah, there are many out there, and we're working on trying to gather that evidence and posting on our website. We've already shared with the Department of Health some of these. So yes, there are many. So someone's proposing that we work on improving access to fresh foods and vegetables. Okay. This is probably something we would have to do with somebody else, right? There are many other organizations that could help with that. Educating women about letting their labor begin on its own. Okay, definitely. So education, outreach. Anything else? Working with DISRIP to embed strategies into Medicaid redesign. Okay, definitely. That would be a huge policy impact. Okay, community health worker services, doula services, centering pregnancy. Yeah, so this is really everything that you're doing, some of these programs. Incorporating preconception, interconception, and routine services. So a lot of this you're doing. And if we're looking at systems approach and working together with all, with various sectors, then there are many other things that we might want to include that we're not particularly doing. Okay, so centralized intake process, yes, that would be helpful. Prenatal and postpartum doulas, okay. So a lot of maternal and child health approaches and programs. Prenatal and postpartum doulas, no wrong door. Is this a campaign? I don't think I've heard of no wrong door before. Yeah, this is the time. These are the times when I wish we were speaking to each other, but
They can unmute themselves and talk.
do you want to unmute yourselves and talk? I don't know if that's easier. So no wrong door means if you need housing or other services, wherever you go, you would get some assistance. Okay, definitely. So Raquel is telling me that if you do want to speak, you can unmute yourself, if that's easier for some of you. So no wrong door refers to access at whatever point they receive help. Okay. So at any point would be okay. We don't have to do it at a certain point. Okay, that makes sense. I get it. Okay. Well, many programs, and we can describe everything that you're doing, but I encourage you to think about some of the social determinants of health that you are not addressing because you don't have partners or you don't know who's doing it in your community, for example. So, yeah, so as we think about systems building and collaborations, I would encourage you to really think about who you want at the table to help improve the determinants of your women's health, the women that you serve. So yes, and to do that, it's important for the various partners to understand where to refer people and what types of service different organizations offer, etc. Service providers across the community would be educated to identify MCH needs and be able to connect clients that need a service. Absolutely. Again, it's back to knowing who's in the community, what agencies are there, and what they offer. So extremely important. So I think the movement to health equity has raised the issue of systems thinking and a systems approach, because there's no way we can reach health equity without involving absolutely everyone, from the women in the communities they live in to all the agencies, all the MITCH programs, working with McVie programs, whatever's available in our communities to do this. Otherwise, we're going to continue to do things in silo and not really have a large systems-wide impact. So I don't have anything else unless you want to, you have some comments you want to share, or any questions about something I presented that you want me to explain, some suggestions you want to offer, anything? Anything else? It was perfect, you understood everything, or you probably knew everything before this. No comments?
Yeah. This is Cheryl Hunter Grant. Can you hear me?
Yes, we can, thanks.
I see now how to unmute. So when do you think that list of evidence-based programs will be coming out? Because we've got a pretty good understanding of health equity and the need to make these changes and involving our partners, despite what might have come out of that partnership tool, because that was a whole another set of issues and concerns. But being better able to know which of these strategies have the documented evidence to achieve the end, because we've got program ideas and we're always struggling with knowing, especially in this age of everything's got to be evidence-based,
Right.
to have that, and not just programs out of the programs, but the systems change, because I haven't come across many that are specific to MCH, and that's what your question was. There are others that show there's improvement in neighborhoods and communities and other stuff, but when you said specifically for MCH, my thinking when you make that statement is showing how you do place-based work that improves prematurity, low birth weight, infant and maternal mortality, not just doing place-based work that increases access to fresh fruits and vegetables. That's where I see a difference, and it may just be that I'm being too myopic in my expectations of what the evidence-based practice for health equity specifically to MCH means.
So first of all, I'll address your last comment and then talk about the evidence-based. So when we talk about programs that are MCH, that are for MCH, but want to address health equity, the point is that we can't just do MCH. We have to partner with others in order to meet the housing needs of our women, in order to meet the environmental issues that our women face, in order to meet, so it's all these other issues that our women face that we need to be able to identify and refer them if we cannot address them. So it's thinking beyond MCH programs, but some of the social issues that those women are impacted with. So everything we talked about, it can be implemented in any health area. So if you're talking about diabetes alone, you still have to talk about what access they have to the right food, to healthcare, etc. So it's really thinking beyond MCH and many other issues that the women face. So the baseline is MCH, but broadening it to looking at social issues and policies, and working with others to address those issues. As far as the evidence-based, we're doing it one by one. So it's not like we have 20 of them. Right now we're doing triage, outreach strategies, etc. But if there is something specific, you know, we are always looking for which one should be next. And working with the state, we can identify, if we know what the needs are, the specific areas, then we can prioritize and focus on those first. I don't know if that makes sense. There's so much out there, obviously we can't do it in a very short time, but the point is to go through them, identify some of the best, and share them with all the MITCH programs.
So I get that, and I thank you. I guess some of the frustration is we are asked to do this, and we don't have as luxury of all those resources and time to get that information, because we want to be able to do things that are making a difference.
Absolutely, I understand.
Doing that, and it's helpful to get more of that, because we don't have enough resources in the grants that we have to get all that support. And working with partners, that's also a reality, because in nonprofit, no one's got the dollars. So it's helpful, especially even if the state is already thinking about what are the key areas that'll get us short, quick wins that are impactful, then maybe that's where the narrowing down can happen. I heard you say about the outreach, maybe that's where you provide us some guidance with what the evidence is saying around how you do outreach, since we're all striving to try to get that crafted in a way that makes a difference, even looking at doing cooperative, outreach cooperatives, so that we're touching on just what you're speaking about, not us all doing the same, that we need to have other partners at the table to do things. But if you're providing us with that model of what we now can do with the people we put around the table to make that change, and outreach may be a good place to start.
Right. I mean, this is a process. You know, we definitely are not going to do all of this immediately. So it's really a process, and which is why we're focusing more on make sure we're building the system, the collaboration, the partnerships, and then, you know, move towards that. But definitely for the evidence-based, we would be sharing them with you. And like I said, if there's anything specific, please let us know, and we can email us, or I think there's a TA section on the website, so that we know what is needed. We can prioritize and share that with you.
Hi, Cheryl, this is Raquel. I do want to echo your frustrations as well, in terms of you're trying to search for articles and literature that are focused on MCH, so that you can make the case that this is an evidence base for our MCH work. And that's, you know, we're having the same frustrations and kind of hitting that bump on the road, where we're doing literature search, for example, in outreach, what are the effective outreach strategies in MCH, and there's really no published literature that says this is what you do. And so what we're trying to do with the lack of data, or with the data we have, is okay, what can we get from this? And it's not an evidence base, but it's a promising strategy instead. And so what is some promising practices that we can put together? And so that's the work that we're trying to, even here as a team and in conjunction with the DOH, is to build those strategies or best practices, in a sense, and not so much evidence-based because of the lack of.
Thank you. That's why I was surprised when they said there were many of evidence-based, because I was not aware of the many. So I thank you for clarifying.
Yeah, it depends. It really depends on the topic. That's, you know, so I think the person that said that it depends on the topic. Some of the very specific on the grounds type of practices, there's sparse information on that. But let's say how to quit smoking for women, or how to address tobacco or obesity, all of those, there's tons. But when it comes to, but it's usually more general. But when it comes to specific on the grounds type of activities or evidence-based practices, that's really difficult. And one of the reasons is because many of us don't publish our successes. And that's why I really think that data collection is important, even if it's annoying and time consuming, but because then we can share what works with other organizations. So, and I think many of the local programs don't have the time to do that. Yeah.
I want to draw your attention also to Elizabeth Crockett's chat message about working across Mitch programs, and that could be helpful. You know, there's some programs that are doing some work that are lessons learned, and we are here. The COE is working towards having webinars or more like conference calls with Mitch programs around promising strategies and evidence-based, if there's evidence-based. But part of those Mitch specific calls would be around lessons learned and what have you learned. So I think to address your comment, Elizabeth, we're working towards that, towards working across Mitch. For example, there are a couple of your Mitch programs that are already participating in Coin Cause, where you are testing some preconception and interconception work at your respective communities and neighborhoods, and you're learning from each other. However, that's yet not to, across all Mitch programs, for example. So eventually we'll get to this where we are having these collaborative calls where we can learn from each other and we can implement some of the things that are on the pipeline here and see how that's working for you. There is a website that's been posted here by Rachel. Rachel, if you want to say more about that, the MCH Navigator trainings on health equity. You want to say more on that?
Hi. No, not necessarily. It's just a good resource that I think everyone can check out. If you scroll down to the bottom, they have some more specific strategies. But really, I mean, a thing that I think that our Mitch programs can be addressing that is more difficult to address is all the very upstream things. So any anti-poverty initiatives is really what's largely having an impact on MCH outcomes, and anything we can do. And we know this, like during the prenatal or even during the preconception period, is sometimes often too late. And so I think as much as our Mitch programs can be involved in those local on-the-ground efforts for anti-poverty initiatives, that would be great. And then I was just, starting to Google as I was listening to everyone, Dr. Kamara Jones. She's the new APHA president and an amazing physician and speaker from the CDC. She does a lot around health equity. And so to be looking at her resources as well, because this is the work that she does.
Actually, just to let you know, she has finished her year as president of APHA.
Oh, really?
Yeah, and now there's someone else. I can't remember his name, but yeah, they just passed the torch on to
Well,
someone
she's
else.
amazing, nonetheless.
She's amazing. I used the little cliff thing as hers, so I used her idea.
Later.
Yeah, so
Yeah,
she's awesome. And she has a lot of clips and videos on YouTube if you want to Google her. So.
Another, I think it's the ANCHIP or Healthy Start. Sometimes they have do have a resource tab where they list evidence-based strategies or promising strategies. That's another resource as well if you're looking for what's out there. But thank you for your comments and your questions. This is really helpful to have this discussion on how this impacts the work in New York State on our goals as well as overall in the maternal and infant health initiative. So any other final or comments or questions? I'll give you a few seconds there if there's any final thoughts, or you can talk in.
Yeah. So well.
Yep. While you're thinking.
While you're thinking, feel free to interrupt us if you have something to say. I think I'll let Rachel tell you about the I was thinking about Rachel from the call. I'm sorry. I'll let Raquel talk about the upcoming webinars.
Yeah, so here's a list of upcoming webinars that we have coming in January. We have the systems building, and it's a 3-part series webinar. We will have Kristen Hasmiller-Lick, who presented at the annual meeting in May, conduct a couple of the webinars, and March 30th is we're going to have that one around systems building, but also looking at the partner survey results and analysis, and how we can use that data to help with MICH and the McV programs. The outreach, this is a part 3 series. This is specifically for the MICH programs. This is around the evidence-based promising strategies work. We've done some literature research and synthesis, and so we want to present to you all what the MICH programs, what we have found, and also part of it is having conversations around how what we can implement based on what we've on our findings, and what will be helpful to you all as well, and so forth. So please go visit our website for additional details and to register for the trainings. There are also additional trainings that will be posted in the next week or so with the webinar and in-person trainings as well. So, but our goal here is to get these 6 months in advance on the training on the website, so that it's on your calendar and you can plan accordingly and have the appropriate staff participate in either webinars or in the in-person training. So I appreciate the patience that you've had and us trying to get you in it with the proper notice so that you can plan accordingly. So we're getting there, and here's some upcoming webinars as well. So thank you so much for sticking with us to almost the 2:30 here. I hope that this was useful and helpful, and you can start looking at your program, seeing what you can do within your own program and community. And we'll talk soon. Thank you, everyone. Have a good afternoon and have a good weekend.